First, scheduling versus staffing. Let's just clarify and get cleaned it up a little bit. Staffing, we're looking at how many hours of coverage do we need based on what we know about our census and our rivals and so forth, and then what type of providers. And as you've heard from Jim, we're really having to rethink what the team looks like, and we are building out support for both physicians and for nurses. Scheduling is really the dance, isn't it? It's the choreography. When do we bring people on? When do we bring people off? How many of you have consistently trouble at the close down? Are you all doing a breathing ED and you close down certain sections at night? How many of you struggle with that every night? Yeah, pretty common. It's very hard to get that choreography right. We'll talk about some things that might help that a little bit. So some basic scheduling issues that we're going to do on our today's journey. Let me show you. First, some basic principles. What we're always trying to do is match capacity to demand. When the capacity is fixed and the demand is not, right? That's our world. We live and breathe in that. We'll talk about matching those two things. This is what your community wants from you, and that's why we look so intensely at who comes, when do they come, what do we do to them, for them, with them. How many of you map that arrival curve by ESI? Did I ask you that already? How many of you are doing that? That's what you're starting to have to do to understand how you should staff and schedule. We talked about weeks, the differences. Now here's a question for you. Better to staff for arrivals or hourly census? That's hard, isn't it? Okay? Historically, I think we've tried to do this. And oh, by the way, understand this. If you have long lengths of stay, if it's 7 hours to get somebody admitted, then your census peak is very much delayed from your arrival peak. See if this makes sense to you. On the other hand, if you have very short lengths of stay, those curves are almost on top of each other. Oh, by the way, this is how the typical hump for arrivals, and we mentioned how it's almost like a fingerprint, it looks slightly different. The whale is the census curve. And what I typically see and why the close down is so painful is we peel off providers too soon. I had one ER last year that they were peeling off providers. They went down to 2 providers at night, and they had almost 100 patients in their department as they started to do that, right? Isn't that rough? So is there an answer to the question? I'm not sure. I think you staff to arrivals, but you can't, as you're closing down, forget what your census is. How many bodies are still in the department, right? Should your acuity breakdown inform how you are going to schedule? Of course it should. And in particular, I would say that this helps you inform which areas you should have open when. And oh, by the way, when I see this many ESI 3s, I want to get the doctor out, and that's why the doctor in triage works so well, because it's the doctor going to decide, are they horizontal or are they vertical, right? That's one of the biggest decisions about all those ESI 3s. If you look this ER, they're seeing 55% ESI 3s. The physician has to decide, do they stay vertical or are they going horizontal? So workload, let's think about workload in a different way. Oh my gosh, this thing is so skittish. There we go, okay. So you give, those little X's are patient care opportunities for the physician in the ER. Okay? And can you wrap your mind around this, that you give a provider some space and then some time. They're going to work over time and space. So look at the green and then look at the blue. Can you think which one is actually a better physician satisfier? Does everybody understand what I'm saying? Like, so I can give you can have a whole pod, 15 beds, and you're responsible, you have to pick up for the next 4 hours. Or I could say, you have half the pod for 8 hours. What do you think? They actually like the green model better because they can front load the shift. Do you know what I'm talking about? Front load your shift. Your workload is at the beginning of your shift. Then you can wrap everybody up and get home sooner. So that model is actually slightly preferred when you trial them and poll physicians. How does a doctor and a patient, or for that matter, a nurse and a patient, how do we put those together? Well, we're just beginning to understand these different models and even develop language for them. So assembly line is there is a doctor staffing one part or another part, and the patient may move. So physician in triage, where the patient is passed back, that is kind of an assembly line. Does that make sense to you? Free range is what most of us grew up with, and that is, here's the patients, and I can go see them. Anybody remember when it was all charts in a rack? And people would go through the rack, and the nurses, tell me nurses if you feel this pain, you're like, nobody's gonna pick up that vaginal discharge. It's still sitting there. Nobody's gonna pick that weak and dizzy. That's the trouble with free range, because you start to have people cherry picking, you know what I'm talking about, okay? Then you can do, and there are some solutions to that, by the way. You can do it by assignment, so these are my rooms that I'm responsible for with my team, and you feed them into me. You can do it rotational. There are places that would go, this patient, that goes here, that patient goes there, especially if you have mirror image zones. This one goes in this area, this one goes in this area. But the coolest in the way of the future, and I predict that by 5 years we'll probably reach a tipping point of this, is to workload level, and there are actually products, computerized products, that will tell you what the workload is in this zone versus this zone, or for this provider versus this provider, and so you would feed appropriately to that area. Does that make sense? So in other words, right now, you can be, if you're doing rotational or just by assignment, you can be coding and they're putting patients in your beds, yeah? Anybody experienced that? So what if there was a program that calculated the workload for you where you are assigned and said, uh-oh, can't give another patient to that side? Anybody got anything like that? I think there's a poster that's something like that. Yeah? So this is going to be very cutting edge where you will have it. Now, Intermountain had, when we trialed it, it's not on the market. I don't know if it'll go anywhere. But it actually calculated the level, suggested to the patient flow coordinator where the next patient should go. But get this, there was an option for a physician or a nurse in a zone, almost like 21, hit me, don't hit me. To cue the front end, I've got a respiratory distress, I can't take anybody right now. And most people didn't misuse it, actually. So you could literally put yourself on red, your nurse could put herself on red, so that they wouldn't get more work right then for a short period of time. And we kind of crafted these silly rules, like you can only be on red for a half hour. Do you like that, though? Does it make sense? Right, because you can be saturated as a provider and not be able to get to the next patient. All right, physician age is definitely playing into scheduling issues, and I think you've all seen that. I don't know, tell me what you think about this. So I know people talk about baby boomers, Gen X, Gen Y, millennials. I sort of feel like at 45 to 50, there's a change. That's what I see in terms of what the expectations are of the job, how much they will work, and so forth. Am I out to lunch? What do y'all think? You're medical directors, you've got to deal with doctors of different ages. Is there something different going on in terms of their sense of the job? Well, what I want you to know, new doctors now, how many hours do they want to work? What are you doing your new contracts at? So, or let me start the other way. 30 years ago, what was an average, so when this doctor had a ponytail, what were the contracts she looked at right out of residency? 1,900 to 2,000 hours. Any of the new doctors want to work that much? Oh my gosh, right? No way. It's changed. It's a different sense of the job. They want to work less. Also, are you noticing, and I know nurses are noticing this as well, some of the new nurses, I don't want to work nights or weekends, right? Where did anyone think that was an option? Anyway. These are still the workhorses, and I will say this when I'm talking to CEOs. I say, when your curmudgeon surgeon or ER doc or whatever retires, you'll miss him because he was a workhorse. And we still, I think, see this. And sadly, do you know there are life disruptions that actually work in your favor when you're trying to fill your schedule? Divorce, because there goes the retirement, right? There's my retirement account. It's got to split it 2 ways. I guess I'm keeping working. Oh, how about a child in medical school, right? At 60 grand a year, right? So some of these things can really, or have a bad investment, you know? So if you know your docs and that comes up, you feel bad for the guy or gal, but you know that's going to help your scheduling. As the physicians age, we need to think about some ways to sort of support them. And you already seen the model change. 30 years ago, you as a doctor, you had a couple of nurses in the ER. Now you have a team. So building out the team to support physicians and nurses is now the way that we're going. You see APPs can build out physician capacity, so can scribes. But also the system can do it. Have you ever heard the statistic? How often, when a physician will log onto a computer in the ER, is the data they're looking for there? About 50% of the time, which is a whole lot of going over and logging onto your computer and looking for stuff. So the best ERs that I've seen have developed systems where information is pushed to that provider. Let me ask you, would your nurses be willing to do that? To get somebody moving, to get them admitted or discharged, would they push the results to the provider? What do you think? Most places that I've seen, nurses are willing to do that. They just don't want the doctor to growl at them when they say, Dr. Welch, everything's back in room 3, grrr, right? So the strategy of pushing information to providers can help build out physician capacity as well. We're paying attention to physician wellness. We're looking at different customized scheduling models, making some concessions for older doctors. How many of you have an age limit where physicians in your group don't work nights? I think, well, and by the way, what is it? I'm interested. 55? Okay. So I have to tell you this funny story. I was working with a hospital in Lake Tahoe. All of the doctors started at this little hospital, very small medical staff, when they were 30 years old. And they said, because it seemed right, well, when we're 50, we don't have to do any night call. They all just became 50 kind of at once. You don't think it'll happen, but there you are, right? And so they're really struggling with, now what are we going to do? And they're torn. We made this promise to each other 20 years ago that at 50 you didn't have to do nights, but ruh-roh, we're all there. So they're sort of struggling with that. So what are some of the other constraints with scheduling? How many of you are in more rural ERs? Do we have anybody in a rural ER? So that has its own challenges in staffing, yeah? Right. How about some inner city urban areas are harder to staff as well? Anybody feel like that's their situation? There are certain places to be sure that geography comes into play. Oops. Oh, for heaven's sakes. All right. So there's local geography, and those are the two places that are hard. There's also something else. Think about this. There's in your building geography. Does the layout of your ER allow you to staff with one provider for these patients? Or is it so, some of them are very cut up and, tortuous, it's impossible for one provider to provide all the coverage, so you have to add a second. Anybody have that? Feel like your geography has strongly influenced how you've staffed? Yeah. And Mike talked about this yesterday, just the night shift itself. And I want to echo what some of my colleagues said. If you have a night shift worker, be it doctor or nurse, people that like the night shift and want to keep doing it, you should covet them. You should honor them and keep them there. This whole, oh my goodness, I am so sorry, guys. I'm literally hitting it once and it's jumping on me here. All right, anybody doing 6-hour or shorter night shifts? For providers or for nurses. So this is something new that's being trialed where you're shorten it in an attempt to get some of that prime sleep. Remember Mike talked about this yesterday, that 9 to 12 is prime sleep and 12 to 3, that whole 6-hour period, more likely to get into stage 4 REM, which is the most restful sleep. And so some places are trying to develop the shifts so that everybody gets a little prime sleep. It's an interesting concept. And then there's huge physician variation that's going to play into how much they will be scheduled and if they'll do those ugly shifts. Their productivity is going to play into scheduling, stamina, and their economic motivation. So let's talk about some of the new scheduling models. And mind you, we're kind of making up the language for this as we go along. So cascading scheduling, make sure you understand that, productivity-based, fallback scheduling, and then red doc, green doc. So what's one complaint I hear everywhere that I go about the ER? The ER batches. Well, they batch. They batch their x-ray orders They batch their admissions. Anybody ever hear that? Anyone complain at your hospital about the ER? Part of it is the nature of ER work, isn't it? In particular, from the physician side, we come in, we're not very good at sign-overs. Nurses are much better at sign-overs. We see patients, keep seeing them, and then at some point we are allowed to stop, usually by custom, and we just wrap up and go. So what happens is that very many decisions are made in that last hour and a half of the shift, yeah? And so what happens? There is batching. Your two strategies to beat batching, one is actually a nurse-driven solution. Have the charge nurse or the patient care nurse in the middle of the shift run the board with the doctor. Dr. Welch, come on, is any of these people, are they going to be admitted? Are you discharging these people? What can we do to get them going? Because what have I done now? It's not all a batch at the end of that shift. We've sort of broken it up a little bit. Anybody doing that routinely, by the way? Yeah, I see it. Great, perfect. And it has to be nurse-driven, because when you try to get doctors to do it, they don't. So, and is it working for you when you're doing it? Yeah, I love that, just running the board midway. But the other is to uncouple shifts. So how many of you have doctors starting at the same time and stopping at the same, like you have double coverage and so you start and stop the same? Anybody have that? That was the traditional way to schedule. But so get this, if you bring people on in a staggered way, then they are starting and finishing at different times. And that's another way to break the batching, okay? And it really does promote continuous flow through your department. Another way is to use simple productivity targets. It's a little bit like that green diagram I told you about. Doctors are asked to see a certain number of patients in that shift, and then they can go home. Now, they can't really go home. They're not going to leave 4 hours early. But they don't have to pick up or own any new patients. Instead, they're asked to start. So all those charts that were getting overlooked, say, look, you've seen your quota. Just at least start these. The understanding is the new guy may come in and have some partially worked up patients. Anybody doing that, and do you understand that? So you would say to a doctor, you need to see, the common one I've seen is 2 patients an hour for your shift. If you see all those in the beginning, then just wrap up. Oh, by the way, start some patients, don't leave them sitting, but you can leave on time. Anybody think that would be a popular strategy with doctors? It actually really is in the places that I've seen it. And then this is something that we did back, in the 80s, the fallback. So you would start in one area that was acute, and then usually, typically, it was you were in the main ER, and then you would fall back to the fast track when it opened. And then when you went home, the next guy fell back to the fast track. Anybody seen that fallback? It was actually very common in the 80s. Yeah. Oh my gosh, are we that old? Fallback, only you and me, I guess. All right. But anyway, and the move was typically to be from higher acuity to lower acuity. All right, anybody track the productivity of their doctors and how quickly they see and dispo patients, identify red doctors, slower, green doctors, faster, and factor that into your scheduling. Anybody doing that? We are going to see this. As physician profiling moves on, we are going to see this. And I'll tell you, where I have seen this, it has worked unbelievably well. And I'm going to take you back to an ER that you've toured virtually here yesterday, where they are doing some very progressive things. And their rule, based on RVUs, patients per hour, lengths of stay, and so forth, you get assigned one category. You're not there for life. And they had one guy who was a red doctor, and he worked really hard, and he got himself to be a green doctor, okay? So it's not written in stone, it changes. But the rule is, as they cascade doctors, no 2 red doctors are ever working together. What do you think? Nurses are nodding. Because this is, and I know you all know this experience. You come in for a night shift, they're hanging from the chandeliers, and you say, oh my gosh, what's happened? They say, oh, Pete and Jim are working. You go, oh, say no more. You understand it, right? You love those partners. Oh, by the way, this group that does this, the Texas Harris Health Group, here's their approach. We appreciate all the docs in our group. Some docs do EMS, some do research, some are really good at teaching. It's not all about the productivity and efficiency. That said, it's much better for our department if we don't put 2 slow guys together. So we honor you, Jim and Pete, but you're slow, and so you can't work together. And that works out well, works out very well. So let me show you how they put kind of everything together. That's the ER you saw yesterday. Everybody remember the one that looked like a museum? This is how they're laid out. There's a sort of a strip of horizontal rooms. That's their intake area. Contrary to what I always say, which is I'm really big on physician triage, they do a very abbreviated nurse triage. They have like 8 or 10 spaces, and it is fast. And I never saw anybody waiting there. They just really fast push that patient to the provider. The pinkish or reddish zone is the major medical area. The sickest patients go there. The thinking is that you will start there so that you'll get the sickest, longest length of stay patients you get early in your shift. See the darker blue, and then there's a lime green. That's major medical. So you'll then go there and take care of the middling kind of patients, okay? And then on the far left hand of the screen, that is their quick care or fast track, okay? And then the little green areas are procedure rooms. So let me tell you how this goes. They start in that critical care area. And oh, by the way, I want you to look at this layout. This was an ER that, remember I told you, I was like, gosh, you guys, you have to run the length of that ER, which is like, I forgot to put in the slide that shows the hallway for this ER. It is so big. And they literally could potentially, as a physician, have patients all the length of that whole ER. But they're incentivized to get rid of patients as they move back through the department, right? I don't want to have somebody in the major area and I'm back at quick care. So I'm trying to get my patients dispositioned pretty quickly. They do 2 hours in the major care, 2 hours in that middle care. Two hours in the most acute area, then in the major care, and then 2 hours in the quick care. Did I totally confuse everybody? Does that understand? You're going to lesser acute places, moving along. And yes, like I said, you could potentially have patients the whole length of that ER, but they tend not to. And your last 2 hours, you are the procedure doctor. What do you think of that? I think this is pretty radical. I think this is very different than what you typically hear. But I want you to think about if that could possibly work for you. So they start in critical care, go to major medical, then to the quick care fast track. You finish as the procedure doc. Okay, physicians in the room, you know it from this end. You've been waiting for ortho to call you back for an hour and a half. They call, and you've just given somebody propofol to put a shoulder in, right? That getting interrupted in a procedure. Or you've done a laceration, you get done and you think, gosh, I think I could have done better if I wasn't interrupted so many times, right? Does this happen to the physicians in the room? Interruption when you're trying to concentrate on a procedure. Oh, if I didn't get those 3 phone calls, I probably could have gotten that LP. Now I got to send it to go get LP'd under fluoro in radiology. Nurses, you know it because you set up a patient for a procedure and now the doctor keeps getting called away. But what if all procedural transactions were done with one doctor who just leisurely went from one patient to the next doing procedures? Wouldn't that be a nice way to do your shift? Because truthfully, how much concentration does it take? How much mental power does it take a physician to just be doing an abscess and a lac at the end? I don't know about you, but I turn off the higher part of my brain, right? I don't have that weak and dizzy lady that I'm still trying to figure out what her problem is. I'm just doing my stuff, my low procedural stuff. And oh, by the way, if there are no procedures, they can leave a little bit early. So they are totally loving that model. Anybody got anything close to that? And remember, they marry it to the red doctor, green doctor idea. So I just think it's brilliant. And those are the positives you can focus on, especially of the procedure doc, which is probably the most controversial to you. Would you give up your procedures, knowing you'll get somebody else's the way the day goes, but would you give up your procedures to another doctor? They've decided that they like this and it works really well. Their nurses, by the way, love it. If you compare them to their cohort at AAEM, look at their physician and PP staffing versus the national. Texas is the hospital that I just showed you. That's very lean physician staffing, isn't it? And actually, I know for a fact that this works very well for them on that count. But all of their other staffing was low. And you can barely see it. That's 2.9 patients per hour. Very highly productive group, in my view. And remember I told you yesterday about their metrics, they've moved down to door-to-dock times of 17 minutes. So the model really, really works for them. And I thought it was something very different. Any questions on that, what you just heard? This is pretty radical, different, new, I think exciting. So there's just a couple of comments for nurse leaders. How many of you have transporters dedicated to the ER? Anybody? Would you like them? Yeah. Okay, so I think this is going to be absolutely critical as we move forward, is that we have dedicated transporters for moving our patients up, out, back, around. The other thing is the whole issue of the support staff for nurses. We can call them techs, but as you know, they can be CNAs, they can be patient care techs, they can be medics. What a lot of states are finding is that the old CNA model doesn't work as well. Why? Because the state restricts what your CNAs can do. So I actually work with one hospital where they are training their CNAs. Remember, your license is a CNA by the state. They're training their CNAs to be patient care techs. Because guess what? A patient care tech is certified and credentialed by your hospital. So they can do whatever you want. Intermountain Healthcare has taken their tech staff, which, oh, by the way, they never have trouble recruiting for techs in the ER, and they've now trained them in ultrasound-guided IV insertion. CNAs often can't even put in an IV. What do you think? Nurse leaders, thoughts about that? What's the best support staff? What I feel like is that the state restrictions on CNAs make me rather have patient care techs that I can train and credential. And mind you, I feel like everyone at Intermountain Healthcare in our ERs is practicing at the top of their license. Nurses are allowed to do local anesthesia, inject a laceration, so the doc just goes in, and the techs have irrigated it, the nurses had numbed it previously, just got to throw stitches in. Anybody like that? How fast could you move and groove in the summer months coming up? So keep that in mind, because your staff at the hospital level can do whatever as a care tech, do whatever you ask them to do. Anybody got a resource nurse in your ER? Okay, yes, we're seeing this as you get. I'm torn about the concept, guys, because I've seen resource nurses that are unbelievable because they just see those fires and put them out as they come. I see others that I really think it's a fluff shift. What do you think? So I think you have to kind of carefully articulate what your resource nurse will do, but this is another new member on the team. And then how many of you have a patient flow coordinator? Okay, yeah, this is pretty cutting edge, actually. We've realized, especially after about 45,000, a charge nurse, there's too much for a charge nurse to do. And we really need somebody monitoring flow, but it's actually bigger than that, because there's front-end flow and there's back-end flow. So the best models that I have seen are where, and mind you, you have to carefully articulate what each one is doing, but wrap your mind around this. A patient flow coordinator who's always keeping an eye on getting patients back. Maybe she even does the doctor says, I want this to go to major care, and she assigns the room, keeping track of how busy everybody is. On the back end, we have a charge nurse, or maybe more than one, monitoring for outflow, monitoring the back, and just overseeing her area and making sure it runs smoothly. So I believe this is the way that we're going in the future. I see some nods, so I think you understand what I'm saying. The old charge nurse model, we outgrew it. So the team is going to look a little bit different. Oops. I stole my own thunder. The nurses are having to worry about some of the same issues, because did you know this? The nursing workforce is the oldest nursing workforce we've ever had, based on new data. So this should have you thinking about a lot of different things, similar to what we thought about. How can we keep these nurses working longer? And does anybody have this heartbreak where some of your best experienced nurses in the ER are going up to gastroenterology, where they don't have to work nights or weekends? And oh, by the way, they're paid more. What's that about, right? These experienced, really valuable nurses. So how can we keep them on? So we're going to be thinking about things. In particular, I'm interested, how many of you have a bariatric lift in your ER? Okay? Sorry, this is where we're going, folks. The obesity problem it's a crisis, it's an epidemic, and we can't have our nurses breaking their backs lifting these patients. And so if you don't have a bariatric lift, at least have a lift team, something like that, okay? Who's dealing with the problem of call-outs? So it's a phenomenon. So can I tell you, 30 years in the ER, I never missed one of my shifts. It's just a different sort of culture, right? So nurses have a problem with call-outs. Whether you are unionized and you have so many days that you're allowed to be sick, what is it in Rhode Island, 9? I think it's 9 in a year.
We have a new policy now, so that's all corrected.
So, well, someone's corrected it, and actually I'm probably going to talk about what you've done. But then many hospitals will say, well, you can have, it's a hospital policy, as a nurse, you have so many sick days. The trouble is, it's viewed on the nursing profession as sort of an entitlement, whereas as physicians, we don't do that. We don't call out sick. We don't feel like there's an entitlement, so we show up for those shifts. And I'm not knocking it, I'm just saying, can we design around it? So how about if we schedule the call-outs? All right, you're going to be sick 9 times this year. When do you want to be sick? I'm not being facetious, but don't we need to get a better handle on that? Because especially very big, high-volume ERs with huge nursing staffs, you can have 10 call-outs in a day. What do you do? I mean, aren't you experiencing this? So how about, like, let's just call it as it is. You can be sick when you want to be sick and operate it that way. Nurses are also, so heretofore, and I feel like nurses have been a little behind physicians in letting go of the 12-hour shift. It doesn't work. So what we have is we have nurses working 12-hour shifts, and there's the area they come in, they're fast track, it doesn't open till 11, they're there at 7 a.m. What do we do with them? So we're going to have to kind of rethink, and I would echo when we heard about the concept of the FTE with nurses. We got to do something different, get away from it. But I believe your younger nurses are going to want this. It will afford you the opportunity to get some prime sleep by splitting the shifts and making them shorter. And some of the younger nurses are liking shorter shifts. I know there's an old school that really loves those 12 hours, but I believe that that's about to change. I think the millennials are going to bring the change with them. Handoffs, let me just say this, and I bow to you, I believe nurses do that better than doctors do. It's been one of the very good things about their culture. They hand off to one another very nicely. Now, how about call management? Anybody having trouble with this? So in the old days, you know, maybe a charger sat there and picked up the phone, maybe the doctor did. You had some calls. There'd be some ambulances, maybe a doctor's office, maybe even a patient with a question. Has anyone felt the burden of this? I mean, I'm working with one year, we actually quantified 100 calls a day. They were complaining about the calls, and I'm like, they're a bunch of whiners. And then 100 calls a day. So we have to have some call management. And so a lot of places are putting that under nursing, I've seen under paramedics, but coming up with a system to manage the calls. You're gonna have to. So if that's not on your radar, make it on your radar, because it's really gonna affect the future.